You see here that the child is growing comfortably. You know, the red dots are the recorded body weights of the child. At 2 months, she was a pink color. The pink color means the child is a girl child. You know that. আর যদি blue hoto, next one is like a blue. This is a boy child. So, at the age of 2 months, the child was almost 5 kgs. At the age of, say, 7 months, she was around 8 kgs. At the age of, say, 1 year, the child's weight was around 9 kgs. So, the child is growing comfortably along the 50th percentile. Another importance of 50th percentile is that তোমরা আইএপির যেটা গ্রোথ প্যারামিটার্স পড়েছো, কোনো পেডিয়াট্রিক্সে কিছু পড়াশোনা করেছো? Probably not. Indian Academy of Pediatrics assumes that 50th percentile of growth is the optimum growth. এরপরে যদি 80% অফ এই প্যারামিটারের নিচে থাকে কোনো বেবি, তাহলে we call it malnutrition. Okay. So this child is growing comfortably along the 50th centile. We know that. Next, other charts you see, like weight for age for boys. This is height for age or length for age for girls. This is length for age for boys. This is head circumference. That is also a must. You must see in your baby's follow-up. For boys, this is the height for weight. Height for weight. See, along the x-axis we put the height. Along the y-axis we put the weight. And you see, according to height, how much the child weighs. If the child weighs less than the scheduled weight for height, then we know that it's a case of wasting. Wasting means the height is okay, but the weight is being reduced. Thin child, that is the wasting. When we are recording the weight or height of the child, we must see whether the child is deviating from normal, and that is the failure to thrive norm. Now this child, she was growing well till the age of 4 months. Then 5 months, then up to 7 months, she was growing well. Up to 7 months, she was growing well. And after that, some acute illness like acute diarrhea. Just assume that there's acute diarrhea happening and the weight falters for a few weeks, and then again the child recovers and comes back to the original percentile. So that is not failure to thrive, because it's a very short-lasting episode. You see, the child is 19 months of age, same child, 19 months of age, and there is another episode of diarrhea which is not treated well. Now what happens? The child grows, but grows in a lower percentile. That is an indication that child is going into malnutrition. And once the child falls into malnutrition, there will be consequences of malnutrition, like there will be frequent illnesses, lack of immunity, and other things like cognition difficulties. So we cannot let it happen. And this is the importance of catching failure to thrive early. You have to detect it early so that it does not progress further. Now, look at this side. If you look carefully, that at the age of 6 months, the child has started growth faltering. Now you see the child at this arrow. The child comes to you at 9 months of age, and you get a history of 3 months chronic diarrhea. Chronic mucoid motions frequently all over the day and night. And you get the history that at the age of 6 months, the child was weaned off from breast milk and he was given wheat products like wheat Celiac, like roti. He was given at that age. And since then, the episodes of diarrhea started. Now you go for the celiac test. There is a disease called celiac disease where gluten part of wheat is not tolerated by the baby. It's sort of allergy. And there are few tests by which you can detect celiac disease. and you have done it, you have maintained a gluten-free diet, and the child was recovering fast. So that is another type of failure to thrive. You have caught it early, you have treated it early, and so the child has come to the original percentile. Now look at that. What are the types? How many types of growth chart you can face in your clinic due to failure to thrive? One is like this. The child is just not growing. The growth curve, which was normal up to the age of say 4 months, it's coming flat. This is one type. Another type is that the child is actually losing weight. That is the second one. And the third one is very shocking. Sometimes you see that the child's weight is much below the third centile. These are three are weight curves and these three are height curves. So this is the third centile and the child has suddenly come below the third centile. That is another thing you can face in your clinic. Now, this is less than third centile, but never jump into conclusion. You see the child for the first time and you see that the body weight is faltering below the third centile. It can be due to some other reason. We shall see that. And that is why I tell you, the definition of failure to thrive is not yet unanimously decided. Definition is still in a blur. But one thing is clear, that failure to thrive is something you cannot miss in your clinic. Because once that goes on and on and on, the child will fall into grave consequences. Now see, the child has come to you at the age of 1 year. He is below the third centile. I mean, below the third, you can say this is the standard deviation, So it is below the third standard deviation. SD3 niche ache. You are shocked to see that the child is very lean and thin and lightweight. He is not growing well. But you cannot jump into the conclusion that the child is not growing well because there are a few conditions like preterm babies, IUGR babies. There are some syndromes, familial short stature and constitutional short stature. All these conditions lead to low body weight since birth. Let us see the next chart. The child was growing like this since birth. He was born at 2 kgs body weight and he never crossed the third centile. He never crossed the line. So we should take it as normal. Now for preterm babies, whether the child is growing normally or not, to see that there is a something called corrected gestational age calculation. Corrected gestational age. Like you are seeing the baby at 4 months, say. The child is 4 months. But you get the history that the child was born at 32 weeks of gestation. That means you should take it, you should take 40 months of gestation, 40 weeks of gestation as normal, standard. So at 32 weeks, he is lacking 8 weeks. That means 2 months. So the corrected gestational age will be 2 months. So you should take it as a 2 months baby. Now what happens due to that? See, if you look it carefully, this is the 4 months vertical column, this is the 2 months vertical column, and this is the body weight recorded by your clinic that the child is weighing 5 kgs. So at the age of 4 months, he is looking miserably bad. But if you take it as 2 months, then it looks comfortably well, and at least 2 percentiles above the percentile you are assuming it to be. So this is the corrected gestational age and this is the postnatal age. Postnatal age, after birth, how many weeks or how many months, and you correct it with the prematurity factor and you get the corrected gestational age. Now, there are few conditions. I have told you that in case of preterm, you can correct it in this way. But for other conditions like IUGR, the baby was born small, short stature, and he was growing like that. So you cannot do much about it. Like the syndromes, like Down syndrome, Turner syndrome, the child is genetically predetermined to follow a lower curve. Like familial short stature, constitutional short stature, they are physiological short stature. We shall come to that when we discuss about short stature. These two are the conditions where there is nothing wrong with the child, not even IUGR. The child was born normally, say above 2.5 kgs, but he is not growing well. That happens in those two conditions of familial short stature and constitutional short stature. So our learning is that finding of weight below third centile is not always failure to thrive. You should not jump into conclusion and push the panic button so that the full array of investigations and the whole attention of your team falls on the child. So there is another way of defining failure to thrive that has been attempted, but even there is fallacy. Let me tell you, if the child crosses two major percentiles, what you will see as dotted lines are two major percentiles. It is taken 95, 90, 75, 50, 25 and 10 percentile as the major percentiles, and the child's weight has crossed two of them. Here also, the child weight has fallen and is falling through two percentiles. This is almost sure that the child is having failure to thrive, but there is a fallacy. Suppose what the fallacy can be? It is what the fallacy can be. The child was born at 4 kgs. When the child was born, his body weight was 4 kgs. Her body weight was 4 kgs. Why? The child could have a born of a diabetic mother or some other, birth defects where you get a large for gestational age. You will see later LGA, large for gestational age, and the child was born like that at 4 kg. But the child has got definite pattern of growth according to his genetic pattern. So the child has to come down to his own percentile. So apparently, if you look at the curve, you will find out that the child is falling through two percentiles. There must be two percentiles between these two lines, but this is normal for the baby. So this is the fallacy. If you see that the child, if you suppose the baby comes to you at this age, and from the past recordings, you see that the child was falling through percentiles. But first of all, you should inquire whether the child was born LGA or not, large for gestational age or not. আবার সেরকম হয়েছে. Now we see that there is no consensus of definition, but ঠিক আছে, এটা ঠিক আছে. হ্যাঁ হ্যাঁ কি হলো? অসুবিধা নেই. Okay, that is much more comfortable. Audible? Everyone? Okay. So we see that there is no consensus of definition, but we have to attempt for a definition, and all those definitions, if any one of them is satisfied, you can take it as a failure to thrive. Well, what are they? First of all, you see it's not a disease, it's just a sign, it's a red flag that needs evaluation and you should not miss. So that's why there are so many definitions around. If the child satisfies even one of them, then you can take it as a failure to thrive. Like weight below 3rd percentile for age, height below 5th percentile for age. Regarding the percentile things, if you don't have the proper idea, then you can go through books of medical statistics like PSM books, I mean the Park textbook of community medicine, there is a there are few pages regarding this thing, medical statistics. You can just go through them, you will get a clear idea. Weight for age curve crossing 2 percentile lines downwards, that is number 3. There are few other definitions attempted, like skin fold thickness on triceps, this part of the body, less than 5 millimeter, persistently low growth velocity. This is a very inconvenient thing because to know the growth velocity, you have to follow up the child for a long time, say about 1 year or at least 6 months. But usually in our clinics, we don't have that time and we have to act early. And weight persistently below 80% of the median for age. These are all definitions you should remember. Now, why that happens? What is the basic physiology? There are 4 basic ways which can lead to your failure to thrive. 4 basic ways. Just think of a car. Think of a car. It needs fuel. You are not giving the fuel. That is the first thing, the insufficient nutrient intake. Next is insufficient absorption of nutrients. You are giving the nutrients, you are giving the fuel, but it's not getting absorbed. You are giving the fuel in wrong place, like you are pouring the fuel on the car itself, not into the fuel tank. So insufficient absorption, we shall see the exact causes afterwards. Insufficient utilization of nutrients, like the car's engine is not functioning. Here, you are giving the nutrients, they are getting absorbed, but due to some reason or other, they are not getting utilized for growth of the baby. And fourth, increased metabolic demand. You have to drive the car along a steep slope, but your fuel is not permitting that. So, there are few conditions where metabolic demand of the body increases, like hyperthyroidism. I'll tell you later. Now, one by one. The first one, that is the insufficient nutrient intake, like lack of exclusive breastfeeding up to 6 months, which is a must nowadays. You have to advise every mother to breastfeed their baby till the child gets 6 months old, and after that, you have to do weaning. So, improper feeding practice, like diluted formula milk. They are purchasing the formula, but because it is very costly, all formulas nowadays are very costly, at least 500 to 1000 rupees for a small tin like that, which the baby will consume in say 5 or 7 days. There are many people whose income doesn't permit that. So what they do? They are giving the diluted formula, simple solution, কম লাগবে, দরকার কম লাগবে, কিন্তু the child will not be thriving well, will not be growing well. So this is it, diluted formula milk. Weaning, সে বাচ্চাটাকে 6 মাসে গিয়ে উইনিং করালো, কিন্তু there are some fixed ideas যে তার ভাত সহ্য হবে না, তার হয়তো বললো যে তাকে ভাত খাওয়ালে পরে ঠান্ডা লেগে যাবে, তাকে অন্য জিনিস খাওয়াচ্ছে, not the proper thing needed by the baby. So due to improper weaning, the child will not get enough food and the growth will falter. Now, GI tract disorder, like there are many things like GERD. GERD means gastroesophageal reflux disorder. The child will throw up anything given to her. So that will lead to failure to thrive. And psychosocial causes like dysfunctional parent-child bonding or child abuse, broken family, and difficult feeders. 2-3 years old baby is not feeding well just because he is not given the food properly. He has not been taught well how to feed himself. That is the difficult feeders. Neuromuscular disorder like cerebral palsy. In cerebral palsy, development is delayed, so the feeding part is also delayed. So that is the first reason, insufficient nutrient intake. Next is insufficient absorption of nutrients. Any case of chronic diarrhea, any case of hepatic insufficiency, chronic liver disease, or chronic diarrhea like celiac disease, inflammatory bowel disorders, enzyme deficiency, all these cases will lead to insufficient absorption, frequent passage of stool, and whatever child is being given, it is being thrown away with the stool. So that is the category 2. Category 3 is insufficient utilization of nutrients like genetic disorders, chromosomal abnormalities. The child's system is not accepting the food. Like chronic infection, everything you give to the child as a food will be utilized to combat the infection, and the child will not grow well. And number 4, increased metabolic demand like heart disease, chronic lung disease, chronic anemia, endocrinopathy like hyperthyroidism. In hyperthyroidism, the metabolism is so fast that you cannot cope it up with the food you are giving, and malignancy last of all. So these are the conditions where you get failure to thrive. Now, what are the specific causes? Like infections. Infections in our country, tuberculosis is rampant. This can cause, or chronic malaria, chronic palazar. All these things can cause failure to thrive. Neurological causes like cerebral palsy or developmental delay of any due to any factor. Respiratory like asthma, cystic fibrosis, bronchiectasis, then cardiovascular, gastrointestinal, renal, endocrine like hyperthyroidism or hypothyroidism. Diabetes mellitus is now happening at around 10 years, and genetic like Down syndrome. Non-organic causes, non-organic causes is 80%. Only 20% of the causes are organic. That means any particular organ is responsible. Mostly we get non-organic failure to thrive, like lack of exclusive breastfeeding, feeding with diluted formula, improper weaning, poverty. The child's family cannot purchase the food, and behavioral problems and dysfunctional parent-child relationship. Fortunately, this is not so common in our country. But behavioral problem, with the time, as the time passes on, the behavioral problems in our clinics we are seeing in much greater number. Now, what are the clinical features you should look for in the history? You get poor weight gain and on standard weight chart. That is the criteria for failure to thrive. That is one. You inquire about the birth history, whether there is any preterm delivery or IUGR or intrauterine infections or unplanned pregnancy. The child was not planned, so there is a lack of normal mother-child relationship. It's a must. In all cases of failure to thrive, in all cases of malnutrition in your exam particularly, you must ask for actually what food the child is getting. So this is must in your history. And any kind of developmental delay you should detect and you should treat. Social and family history like dysfunctional family, in those cases you must look for how the child is behaving towards the parents, how the parents are behaving towards the child, and you should take a proper family history. এটা আবার এরকম হয়ে গেছে বোধহয়, উপরের দিকটা দেখা যাচ্ছে, দেখো। হ্যাঁ, that's it. Okay. Now on examination, what you get? On systemic examination, you get you get general survey and systemic assessment to rule out any organic cause. And I tell you, in cases of failure to thrive, at least 70-80% cases, if you examine the child thoroughly, you will come to know whether there is any organic cause behind the malnutrition, behind the child not growing well. Almost 70-80% cases. By thorough examination, you can exclude the organic causes. Okay. So laboratory investigation, if you are not satisfied with your clinical examination, then you go for laboratory examination. Most cases, it's not needed. Most cases, if you are a good clinician, then you can exclude the organic causes through your clinical examination only. Otherwise, you go for the investigation. There are some basic investigations like complete blood count and ESR, urine test. There might be urinary infection. Because of urinary infection also, this is called hidden urinary infection or latent urinary infection. The child does not grow well. Now, tests to rule out tuberculosis. Tuberculosis is so rampant in our country. You do a Mantoux test. I hope you know what Mantoux test is. You do a chest X-ray. You do a PCR for tuberculosis. IGRA, interferon gamma release assay. This is a very modern test to find out tuberculosis. Urea creatinine to find out if there is any renal cause or not. Thyroid function test, whether hyper or hypothyroidism, and bone age determination. We shall come to that later. Bone age determination is a must if you order any investigation at all for the you know short stature or failure to thrive children. And there are a few specific tests like IEM, inborn error of metabolism screening, very costly also. Karyotyping, if you suspect any case of Down syndrome. Sweat test for cystic fibrosis. Celiac etiology for celiac disease. Endoscopy for GERD, gastroesophageal reflux disorder or inflammatory bowel disease. And radiological test for child abuse like the bone scan and others. Next, management. There are few red flags for which you must do hospitalization, like severe malnutrition with complications. Sam, you will study later on severe acute malnutrition. That is one of the causes of failure to thrive. You should advise for hospitalization. Now, for diagnostic workup, if non-organic, organic FTT is suspected, there is a typing error here. If organic failure to thrive is suspected, to do the investigations, you should advise hospitalization. Now you are doing the nutritional management, like you have calculated the calories, you have calculated the proteins, the needed by the child according to the age, according to the body weight. You are giving that for 1 month and still the child is not growing well. Then you should hospitalize the child for observation and treatment. If any kind of child abuse is suspect, you must order for hospitalization. So these are the red flags. These are the red flags. You should not keep the child at home. You should hospitalize for 5 or 7 days. Then you should release. Next, management. One is diet management. You know that very well. For malnutrition, you have to give him calculated amount of calorie and protein. Medical management, if you suspect any secondary issues like tuberculosis, you give anti-tubercular drug. For thyroid, hypothyroid, you give eltroxin. Psychosocial management, you have to plan according to the psychosocial problem. If the child is suspect is suffering from depression or ADHD like thing, attention deficit hyperactive disorder, and that's why the child might not be taking the food, then you should take help of a psychiatrist. And developmental management, early detection and therapy, that is important. Okay. There is an algorithm I have given, but there are very intricate details about failure to thrive, how to manage. Those 2 pages, I hope, আবার উঠে গেছে ওটা প্রিয়ঙ্কা ওকে এটা কি হচ্ছে গো আচ্ছা যাই হোক ঠিক আছে I hope you will get access to the the slides and all. If you don't have, then I'll send it to you through WhatsApp. Any of your class representatives can approach me. That is taken from a very authentic textbook, and that is a very authentic algorithm how you should proceed in a case of failure to thrive. 2 pages, but not worth discussion here because time will not permit. So, end of topic 1. Next we go to the next topic, that is short stature. You know the short stature means? Stature means either the length or the height. Below 2 years, length. Above 2 years, height. The reason is not worth mentioning here. All those discussions will take longer time, and you will read it in your textbook or in your clinical classes. Okay, now short stature. Definition of short stature is much more straightforward. It's not as complicated as failure to thrive. Any child in your clinic who is below the 3rd centile for age and sex, having length or height, or more than 2 standard deviations. It's regarding the height only. Short stature means height. So, short stature means the child is not growing well in height. So either third centile for age and sex or below 2 standard deviations. I hope you know what standard deviations are. Look at that. This is the second standard deviation line. This is the 0 standard deviation, that is the normal line. And this is the third standard deviation line. So here the red dot you see, the child's weight recorded is she, it's a girl child, and it is much below the third standard deviation. So the child has short stature. This is the definition of short stature. But one thing I can tell you, that if the child's height falls below second standard deviation but above third standard deviation, usually they are physiologically not growing well. Usually. Now, what are the physiological causes? We shall see. Physiological causes, there are two. One is familial short stature, because the parents are short, the child is short. That happens. And secondly, the constitutional short stature, because in the constitution you get the history that either of the parents was growing in their childhood like this. The puberty will come late. Now let us tell me one thing, otherwise you will not understand that. Because up to puberty, the child has got a definite growth velocity, that is about 4 to 6 centimeter per year. That is the pre-pubertal growth. And as long as puberty doesn't come, the child, if you feed him well and if he is free from chronic disorders, then the child will grow in that fashion, 4 to 6 centimeters per year. If it is below 4, or if it is, some say it is below 5, then it is abnormal. So the child will be growing well till puberty comes. As soon as puberty comes, there will be a growth spurt. The child, at least 8 to 12 centimeters per year, the child will grow for a few years, let's say 3 years or 4 years, and then what happens? The growth will stop. So, if the puberty comes late, then the child will have additional 2 to 3 years time to grow normally. And after puberty, we'll know what happened. We all know that the child's growth stops. So, constitutional short stature are those child where the puberty spurt is delayed. Usually, you get a family history. So, final height becomes normal. See, those two curves, the upper ones are for height and the lower one are for weight. You concentrate on the height part. One is the blue dots, or the black dots I can see. Other is the red dot. There are two children, child 1 and child 2. This is child A. See this arrow. This is the mid-parental height. There is another new thing to you. Mid-parental height is, you get the mother side, you get the father side, you get an average. Add them, divide it by 2, that is the mid-parental height. And if the child is this is a boy child, so target height for the child will be mid-parental height plus 6.5 centimeter. If the child were a girl child, then we could have calculated in as minus 6.5. So, mid-parental height plus 6.5 or minus 6.5, that is our target height. This is the target height for that child, and the child is obediently following that curve. Suppose you are seeing the child for the first time at, say, about 10 years, and you see the child is stunted. He is not growing well in stature. Then will it be your decision to take it as short stature? Yes, but this is physiological, because if you know the previous height, you find out the old prescriptions, the height should be mentioned there, and you plot it along the edge line, and you will get a curve like this. The child is very thoroughly following the target height. So, this is physiological short stature. You need not do anything about it. The second one, the black dots, they are the constitutional delay in growth and puberty. Why? Because, the puberty has come at this age. That means at about 15 years. For a boy like this, the puberty should have been at 12 years. 11 to 12 years, the child starts growing. But here, the child has got 3 years in addition. So, the final height is just as good as the parental height. নর্মাল জেনেটিক হাইট তার যতটা হওয়া উচিত ছিল, ফাইনাল হাইট কিন্তু ঠিক সেইখানে পৌঁছে যাচ্ছে। সো দ্যাট ইজ কনস্টিটিউশনাল ডিলে ইন গ্রোথ অ্যান্ড পিউবার্টি। There are other pathological causes of short stature like malnutrition, like chronic systemic diseases. There are many chronic systemic diseases. Let us see. Metabolic bone disease, endocrine causes, genetic syndromes, skeletal dysplasias, psychosocial dwarfism, and drugs. You have to study from your book and you can study the slides also. Nota 40 na? Okay. Now regarding short stature, there is a very peculiar thing. We can divide it in some other way so that our clinical spectrum becomes more specified, like disproportionate and proportionate short stature. Disproportionate short stature means upper segment lower segment ratio is not normal. In your clinical classes, you will be taught how to look for the upper segment lower segment ratio, the upper part of the body and the lower part of the body, taking the symphysis pubis upper border as the dividing point. So normally at birth, you know anything about it? You haven't studied. At birth, this is 1.7:1. That means the upper segment is bigger than the lower segment. The longer the child grows, it becomes nearer to 1:1. At the age of say 10 or 12 years, it becomes 1:1, and in the adult life, it is 0.9:1. That is for us, the upper segment is slightly shorter than the lower segment. Now for a child who is disproportionate, the upper segment lower segment ratio is abnormal, then you can find there may be short limb or there may be short trunk. Short limbs means upper segment lower segment ratio is more than normal. The upper segment is bigger, the lower segment including the limbs is shorter. And for a short trunk dwarfism, you know, the upper segment lower segment ratio is less than normal. So this is where you can divide the children clinically into two categories. That is very convenient for a clinician. Now, what are the short limb dwarfisms? Like hypothyroidism is a very important cause, and there are a few skeletal dysplasias where the limbs are short, and for that also can be divided into three parts, into three types. One is rhizomelic short limb, where the proximal segment of the limb is short. Mesomelic shortening, that is the middle segment of the limb is short, and the acromelic short limb, where the distal segment of the limb is short. Details not possible here, but if you divide the child along this way, then your number of differential diagnosis becomes smaller. That is a very convenient thing for you as a clinician. And for short trunk dwarfism, mucopolysaccharidosis and spondyloepithelial dysplasia, where spine is affected, this thing happens. That is the upper segment is bigger than the lower segment. Next. For proportionate short stature, two very important causes, familial short stature and constitutional delay. Other things like malnutrition, small for death, systemic diseases, chromosomal and genetic syndromes, and endocrine causes except hypothyroidism. They fall into this category. Now, abar eta ei hoye geche go. Okay. Now, clinical features, what are the features you should look for? One is definitely the anthropometry. Height or length will be below 5th centile, that is by for definition. In pathological short stature, the growth velocity usually is less than 5 centimeters per year. Just now I was telling you the normal growth rate is 4 to 6 centimeters per year, and if it is below 5 centimeters per year, we usually assume that something is wrong with any organ. Usually for physiological short stature, we have seen the two graphs. The child was growing well, though short but growing well. The steep of the curve is normal. That was the growth velocity becomes normal. But if that is abnormal, then you suspect some sort of pathological short stature. Okay, calculation of mid-parental height, you never forget in your clinical practice. Height age and bone age and chronological age. These are three very interesting things. Let me tell you. Height age. Height age means, suppose the child is say 100 centimeters tall, and from your graphs you go and see that 100 centimeter is normal age for a 4 years old child, but your child's age is say 10 years. So you can say that my child's is 10 years old, but still the height age is only 4 years. That is very important. Other thing is bone age. You know, at birth there are only two epiphyses you can look for. In a newborn baby, there are only two epiphyses on X-ray you will find. And as the age progresses, the number of epiphyses, their formation, their size, and the fusion with the diaphysis will progress. So, seeing the X-ray, actually the norm is to see the left hand and wrist X-ray done. This is done for bone age estimation. But by seeing that X-ray, you can assume skeletal age, that is bone age. So that means skeletal maturity, how far the child has progressed to skeletal fusion. Low bone age means the child has got few years left before skeletal fusion occurs. That means the height stops growing. So lesser the bone age, the more years the child have before growing more. Now height age, in familial short stature, just imagine in familial short stature what can happen. Height age is definitely less than chronological age. Chronological age means postnatal age. So height age is definitely less than chronological age, and bone age will be as good as height age. Bone age is as good as chronological age, because everything is normal for a physiological familial short stature. But for constitutional delay in growth and puberty, that is condition where the bone age is delayed. Bone age is delayed. That means the child has got few more years to grow. So this is what happens for constitutional delay in growth and puberty. The bone age is equal to height age, and that is less than your chronological age. That's the way you remember, because in this condition the child will grow a few years more, so the bone age must be lower than the chronological age, and height age is lower than chronological because the child is short. That's simple calculation. Okay. And in malnutrition and other systemic illnesses, because the body is not permitting for skeletal maturity, so the height age will be low. Height age will be lower than chronological age, and same thing, bone age will be lower than chronological age. Is that clear? Okay, you get the slides, you think for a while, and you will come to know. So our the gist of the discussion is that bone age will be less than chronological age in all cases of short stature, excepting familial short stature, where it will be bone age will be equal to chronological age, and precocious puberty, where bone age will be higher than chronological age. Precocious puberty means the puberty will come earlier, so the bone age is advanced in comparison to chronological age. Okay. So regarding history, regarding the anthropometry, you have done all these things. Regarding history, you take the birth weight, it can be low. The birth history, it can be antenatal, intranatal or postnatal history of birth asphyxia there may be, or breech presentation. Any problem during birth will have its effect on the baby, on the growth of the baby. History of chronic infections, history of polyuria, polydipsia for diabetes mellitus and your renal disorders. Constipation and delayed milestones will be there in case of hypothyroidism. Now these are the features you must look for. This is a must look for, like age of onset, birth weight, family history of short parents, upper segment, lower segment ratio, height velocity and bone age. There is a chart about this. I'll give you the chart, and the 5 or 6 common causes of short stature are divided along these these points. So these points, what I should say, these points you cannot miss in your clinical examination or in your long papers. Those two topics given to me today is important for your long question, I mean your theoretical papers, as well as you can get cases in your practical exam, final exam. This is a, এটা একটু উঠে গেছে কি তলার দিকটা দেখা যাচ্ছে না. This is an algorithm for short stretch, but this is simplified algorithm. Not a Panchash, na? This is a simplified algorithm. First of all, they have told you to take the mid-parental height and then divide it into 2 categories, and then you look for the bone age. It can be normal, it can be delayed, it can be advanced, and again the category becomes clear. There are a few causes, there are a few causes, and there are a few causes. So this is a very handy algorithm taken from one of your textbooks, and you study them. You study them, then you know well. Well, management of short stature, physiological causes, counseling. Except counseling, nothing can be done. And you impress the parents that shortness is not everything. There are other aspects of life which can be achieved in spite of the child's shortness. Dietary therapy for malnutrition, treatment for pathological causes with growth monitoring. Like growth hormone therapy is given for growth hormone deficiency disorders. Orthopedic surgical problems, procedures are nowadays done, like limb lengthening, that is also done. This is another algorithm for short stature, complicated, but you go through them and you will find out many new things. Okay, these things I have given you. If you don't understand, if you have any problem with those, you can approach me later also. Okay, just go through the slides, go through your textbook, and then your exam oriented knowledge will be complete.